organizers of this pediatric conference for allowing me to present this topic today. They have no conflict of interest to declare, and the objectives of my presentation today are twofold. The first one is to identify the most common causes of respiratory distress in newborn infants, and second, to describe the initial approach to the management of respiratory distress in newborn infants. When you face a baby with respiratory distress, the most important things to differentiate, first of all, is the origin of that distress, either if the distress is coming from the lungs or the distress is coming from the heart. So respiratory versus a cardiac cause. And there are many things that we can look at to have a good idea if this is cardiac or respiratory. First of all, we look at breathing. Most respiratory distress are associated with retractions and indrawing, while cardiac causes usually are not associated with retractions or indrawing, and sometimes just tachypnea. When you look at the cardiac evaluation in the respiratory cause, it's usually normal. In cardiac, you can find abnormal pulses, weak pulses, or a murmur. In respiratory causes, the second heart sound usually is normally split. In cardiac causes, sometimes depend on the type of cardiac lesion you're dealing with. You could be looking at a single second heart sound. When you look at the chest X-ray on a baby with respiratory stress from respiratory cause, you will find usually an abnormal X-ray. While in a cardiac cause, the X-ray is usually normal or associated with an abnormal heart shape. When you look at the level of PCO2 in respiratory causes, usually the PCO2 is elevated, while in cardiac causes usually is normal or low. When you look at the pulse oximeter, usually the oxygenation improves when you give oxygen. However, if it's a cardiac cause, especially if it's cyanotic condition, there's no change in the oximetry when you give oxygen, and that's usually reflected in the hyperoxia test that always should be done with a arterial PO2 and not pulse oximetry. In the case of respiratory cause, usually when you give oxygen, the PO2 rises, while in cardiac causes, the PO2 remains unchanged. So when you look at the etiology or the origin of the respiratory stress, it's important to know the age of the infant, because the etiology could be quite different if the baby is younger than 6 hours of age or older than 6 hours of age. If the baby is younger than 6 hours of age, the most common causes of RDS or surfactant deficiency, congenital pneumonia, transient tachypnea of the newborn, a pneumothorax, or lung malformations. When you have a baby that has respiratory stress that develop later on after 6 hours of age, usually you have to think about congenital or acquired pneumonia, a pneumothorax that could develop later on, also a lung malformation, aspiration syndromes, patent ductus arteriosus, especially if it's a premature infant. It could be shock related, or it could also be related to congenital heart disease, as we explained before. And also in cases that have baby with significant HMD that develop severe respiratory stress later on, it could be associated with a pulmonary hemorrhage. Now, we can also differentiate the etiology of the respiratory stress based on the origin of the condition. Usually we like to divide it into pulmonary and non-pulmonary. In the pulmonary causes, you can differentiate between parenchymal and not parenchymal. Within the parenchymal pulmonary causes, we have RDS or surfactant deficiency, pneumonia, meconial aspiration syndrome, PPHN, transient tachypnea of the newborn, pulmonary hypoplasia. In non-parenchymal pulmonary causes or extra-parenchymal, you have to look at upper airway obstruction, pneumothorax, pleural effusion, congenital diaphragmatic hernia, or diaphragmatic palsy. Now, the respiratory stress can come from other places rather than the lungs. Those are the non-pulmonary or extrapulmonary origin. And in here we have what we discussed before, coming from the heart, when you have congenital heart disease or congenital heart failure or patent ductus arteriosus or a vascular malformation. The respiratory stress could be related to metabolic conditions like congenital metabolic acidosis or hypoglycemia, hypothermia, or sepsis. Respiratory stress could also be secondary to a brain abnormality like intracranial hemorrhage, asphyxia, or drugs that can also give respiratory distress. Problems arising from the blood like hypovolemia, polycythemia, hyperviscosity, anemia can also cause respiratory distress in the newborn infant. And finally, the respiratory stress could be related to abdominal causes, like when the baby has necrotizing enterocolitis or a large mass or a pneumoperitoneum that can cause also respiratory distress. Now, how do we do to differentiate between all these causes? Now, the most useful test that we can do in any baby with respiratory stress is a simple chest X-ray. And the chest X-rays can give us very, very useful information about the etiology of that respiratory distress. So I would usually like to divide what we see in the X-ray based on, for example, the lung volume. If you do an X-ray and the lung volume is low, possible conditions that can give you that is usually RDS or surfactant deficiency, pneumonia, or pulmonary hypoplasia. Here we have two X-rays, one on the left and one on the right, that are associated with decreased lung volume related to surfactant deficiency. As you can see, these two X-rays are associated with decreased lung volume due to bilateral diffuse atelectasis. Now, when you do an X-ray and you find that the lung volume is normal or high, then you have to think about other conditions like meconial aspiration syndrome, a transient tachypnea of the newborn, pneumonia, or hyperventilation or hyperinflation. And here we have two X-rays that shows increased lung volume. As you can see, the way we define high volume is by counting the number of ribs. When you have 9 or more ribs posteriorly, when the diaphragms are flat, when you have increased lucency of the lungs, and when the ribs are more horizontal, you are dealing with increased lung volume. Here on the left, you see a picture that is compatible with meconial aspiration syndrome. And here on the right, you have an X-ray that is compatible, a baby that is intubated, that is compatible with air trapping from the ventilator or hyperinflation. You can see here the ribs are more horizontal, the diaphragms are flat, and if you count the ribs, you will see that this X-ray has 10 ribs. So these lungs are hyperinflated. Also, when we look at the X-ray, we need to see if the lesions that we're seeing in the lungs are diffuse and homogeneous. If they are, then you have to think about surfactant deficiency and pneumonia. Here again, we have two X-rays, one on the left and one on the right, that are compatible with either severe whiteout HMD or a congenital pneumonia. As you can see, this X-ray shows a bilateral, diffuse, homogeneous lung disease. So both lungs are equally affected. Now, when you look at an X-ray and you find that the X-rays are showing a pattern of more diffuse but heterogeneous lung disease, then you have to think about other possible causes like meconial aspiration syndrome, transient tachypnea of the newborn, and also pneumonia. Again, here we have two X-rays that shows an heterogeneous lung disease in which both lungs are not equally affected, and like within the same lung, the lesions are not the same on the top and the bottom. So these two X-rays could be compatible with meconial aspiration syndrome or pneumonia. Now, when you do an X-ray, you can also see pleural effusions, and pleural effusion could be related to or secondary to a pneumonia. It could be secondary to a chylothorax. It could be also secondary to more rare conditions like pulmonary lymphangiectasias. I'm going to show you two X-rays here showing pulmonary effusions or pleural effusions. Here on the left, the effusion is unilateral on the right lung, as you can see by this line here. And here on the X-ray on the right, you can see is chylothorax. And finally, when you do an X-ray, you can see 60 changes on the lungs or a mass. When you see that, you have to think about CCAM or congenital diaphragmatic hernia or pulmonary sequestration. Here I'm going to show you two X-rays that here on the left, you can see this X-ray could be compatible with congenital diaphragmatic hernia. And here on the, because you don't see the left diaphragm completely here, so most likely this is valve. Now here on the X-ray on the right, you also see 60 changes on the right lung, but you see the diaphragm, the line of diaphragm normal here, so most likely this is related to CCAM. Very good. So when you have a baby with respiratory stress, one of the first things you need to do is to try to define the severity of that distress. There is a score that was developed many years ago by Dose, published in 1970, that is still very useful and very practical, that will try to determine how severe the distress that the baby has. And this scoring system has 6 items: respiratory rate, retractions, granting, oxygen requirement, breath sounds on auscultation, and the degree of prematurity. And you have 3 numbers, like the Apgar score, 0, 1, and 2. So when respiratory rate is 40 to 60, 0, it's normal. 1 is 60 to 80, mildly tachypnic. And when you have more severe tachypnea, is 2. When you have no retraction is 0, intercostal or subcostal retractions is 1, and when you add sternal retraction is 2. When you have granting with stimulation is 1, and when you have continuous granting arrest is 2. The oxygen requirement is less or more than 30%, give you 1 or 2 points. When the breath sounds are decreased or absent or barely heard, you get a 1 or a 2. And finally, the degree of prematurity will give you also a 0 point if it's more than 34 weeks. 30 to 34 weeks will give you 1 point, and less than 30 weeks will give you 2 points. And I'll show you now how we're going to use this scoring system to determine the management of the infant. So if you add up all the points, you get a score of less than 5. That would consider mild distress. If you get a score of 5 to 8, we'll consider moderate. And if you get a score of more than 8, that's considered severe. So how do we manage the respiratory stress? So if you have a baby that has labor respirations, is tachypnic, breathing more than 60 per minute, and is either on CPAP or oxygen by nasal flow, you most likely are dealing with a respiratory cause. So at that point, what you have to do first is try to maintain the oxygen saturation between 90 and 95, adjusting the oxygen accordingly. And after that, you try to calculate the respiratory score if the baby, of course, is breathing spontaneously. If the baby is intubated already, the score is not useful. So if you get a score of more than 8 or severe, or the baby is having apneas requiring positive pressure ventilation, then that baby should be intubated if not already intubated. And if the baby is intubated, you should check for the patency of that endotracheal tube and the position, just to be sure that the tube is in good position. If the score is 5 to 8 or moderate, or the score is less than 5 but lasting more than 6 hours, then you need to consider adjusting the CPAP. If the baby is not on CPAP, the baby should be put on CPAP, and if the baby is already on CPAP, you should consider going up on the CPAP pressure. In both those cases, either with severe or moderate scoring, at this point you should be doing a chest x-ray, a blood gas. You should try to obtain a vascular access, an IV, to give fluids and glucose. Try to optimize ventilation, especially if the blood gas shows high CO2. And you should try to consult a senior person or a neonatologist. If the score is less than 5 or mild, lasting less than 6 hours, and the baby is requiring less than 30% oxygen to maintain the SATs between 90 and 95, then you could wait and just try to see if you can establish a working diagnosis using the history and physical examination and the chest x-ray, just to establish a more specific treatment for the condition you're dealing with. So when you try to establish the diagnosis by history, physical exam, and a chest x-ray, then you try to give a specific treatment for the condition you're dealing with. So if you're dealing with pneumothorax, you should consider a needle in the chest, or draining, putting a chest tube, depends on the severity of the pneumothorax and the respiratory stress, and do a follow-up x-ray. If you're dealing with RDS or hyaline membrane disease, you should consider giving a surfactant according to the degree of the respiratory distress and the amount of oxygen the baby is requiring. If you're dealing with transient tachypnea of the newborn or mild RDS, then you could wait. You could reassess the diagnosis and management if the respiratory stress doesn't resolve within 6 hours of birth. If you're dealing with meconium aspiration, pneumonia, PPHN, or others, then in that case is supportive care, as we're going to discuss that later on. In any case, always follow up your treatment with a respiratory score to see if it's changing. Always try to optimize oxygenation, try to keep the SATs between 90 and 95, and always optimize respiratory support, doing a follow-up blood gas to look at the bicarb and the CO2 to see if there's any respiratory or metabolic acidosis associated with the distress, and try to adjust your ventilatory settings and wean or increase the support accordingly. So the initial management is always supportive. Always, no matter what type of respiratory stress you're dealing with, always try to maintain a normal temperature, normal glucose levels. Try to give fluids in the form of glucose and water. Always check the blood pressure, and if the baby, if antibiotics are indicated, consider giving antibiotics after a full septic workup. Always maintain adequate oxygenation, as I said before. Always attach the pulse oximetry on the right side, on the right wrist, pre-ductal, and try to keep the SATs 90 to 95. If the baby is grunting or the oxygen requirements are high, always consider nasal CPAP, which is one of the most useful treatment you can do, one of the most important initial treatments you can do for any type of respiratory distress in the newborn. Why? Well, CPAP has many effects. CPAP helps to develop an effective functional residual capacity, reduces atelectative trauma, improve oxygenation, decreases airway resistance, helps to splint chest wall and airway. Also, we know that improves surfactant metabolism, decreases the work of breathing, promotes regular breathing, and the way we use a nasal CPAP is usually by using short binasal prongs that have been shown to be more effective. The type of prongs is not that important. The important is that they should be short and binasal. So after that, always maintain adequate ventilation, either by intubation and ventilation, or in the meantime, by bag and mask. So what are the indications for intubation and ventilation? These are not written in stones. These are just guidelines that I will give you right now. When you have severe respiratory stress despite nasal CPAP, consider intubation. When you have baby that has severe apneas on CPAP, consider intubation and ventilation. When you have suspected severe airway obstruction, when you are requiring very high oxygens on nasal CPAP, when you have severe metabolic and or respiratory acidosis, you should also consider intubation and ventilation. And also when you have congenital diaphragmatic hernia, that baby should be electively intubated. So in summary of the initial respiratory distress management, first of all, narrow down the possible causes of respiratory stress using the different algorithms that I gave you before. Quantify respiratory stress by using the scoring system. Use judicious use of oxygen. Don't give too much, don't give too little. Try to maintain the SATs pre-ductal between 90 and 95%. Always try to use early use of nasal CPAP. Avoid ventilation lag injury, especially if you are intubated, using high pressures. And supportive care, don't forget temperature, fluids, antibiotics, and so on. Thank you very much.
Robin, thank you very much. May I ask you a question, please? And first, thank you very much for all what you did for us in 2020 and 2021 and this year, 2022. Thank you very much for your contribution.
My pleasure.
Actually, we don't have just simple cases of respiratory distress. We have cases of respiratory distress with severe pulmonary hypertensions, and we have respiratory distress with severe.
صوت واطي يا دكتور سامح، لو ممكن أحمد يعليه شوية. صوت واطي فجأة. أيوه.
تخلي يعني الصوت أعلى شوية، لاود شوية. Do you hear me?
Yes, we can hear you.
Okay. Actually, we don't have just simple RDS or respiratory distress. We have neonates with severe respiratory distress with severe pulmonary hypertension, and we have neonates with severe with congenital heart disease and with early neonatal sepsis. Rarely we find neonate with just simple respiratory distress. That's why our cases looks complicated. I don't know why.
Yeah, well, I wonder.
I mean, there's a combination of pathology in our patients.
Yeah, I mean, we have always to remember that the how stable our newborns are when they are delivered, when they are born, depends a lot on the obstetrical care also. So you have to be sure that the obstetrical team is using proper guidelines to deliver the babies at the right time, especially suspect chorioamnionitis or you suspect severe asphyxia. Those are the babies that are usually born in bad shape, either because they're septic or because they have suffered acute asphyxia. And those are the babies that will develop pulmonary hypertension. So you have to be aware of that. So obstetrical management is crucial before the baby is delivered. That may be the reason. We also see that kind of babies when babies are born outside our tertiary care centers. They're born in the peripheries. And as Dr. Sesha explained, the golden hour was not applied properly, and those babies do not transition well. So those are the babies that develop severe respiratory stress because, again, they either been kept hypoxic in the first few minutes, few hours of age, or they haven't been able to establish good lung volume because the management was not appropriate. So yeah, it's possible that maybe the reason either obstetrical management before delivery or initial postnatal management in the babies is born outside the tertiary care center.
Okay, thank you very much.
معاك يا دكتور سام.
Okay, we can go ahead, please.